So let's get started with today's clinical topic. I am so pleased to welcome back Dr. Jamison Spencer, a native of Boise, Idaho, and he earned his DMD from Southern Illinois University and then did a master's program in craniofacial pain at Tufts University. He's a diplomat of the American Board of Craniofacial Pain, as well as the American Board of Dental Sleep Medicine. He is the director of the Center for Sleep Apnea and TMJ in Boise, and he is an awesome teacher. We've worked with him quite a bit. He has some online courses on our online site. Excellent way to get started if you want to take those courses. And his topic today is choosing the right occlusal appliance for your patient. If his lecture is as clearly stated as his title, we're in really good shape. So, Dr. Spencer, it is all yours. Take it away.
Can I interrupt for 1 second? I'm so sorry. Dr. Jamison, we have a survey. If we can just have the attendees just fill this out really quickly, and then it will go away.
You bet.
Thank you. And then you can go ahead.
Okay, Nicole?
Yes, we can see them. So you can go ahead and start.
All right, great. Thank you very much, Dr. Park, and for the whole panel. I always, that's one of the gifts that I have from participating in these GlideWell webinars is I get to learn, like all of the rest of the attendees here, from our illustrious panel participants there. There's never a time that I don't. So let's jump right in here, choosing the right occlusal appliance for your patients. So, and I'll use the term nightguard and oral appliance and occlusal appliance, stuff like that, somewhat interchangeably, but we're typically thinking nightguards in these cases. So let's talk about first, why would we not use a nightguard? So here's my reasons for not using a nightguard. Your patient doesn't have any teeth or hardly any teeth. That'd be a reason. Or your patient has teeth, but they're baby teeth and they're going to fall out soon. So in other words, we don't treat a lot of babies with night guards. There are some night guards that are designed for children, that are designed to help encourage growth and development. That's not our topic. So our topic is really for our adult patients today and those who we could use a night guard with. And I'm starting with saying you really want to protect people's teeth. So the reason to use a night guard is your patient has teeth. They'd like to keep those teeth for as long as possible for the rest of their life. So are night guards contraindicated? Not typically. Most of your patients could benefit from use of a night guard to protect their teeth, particularly if they have any restorative already in place. But even if they don't, just to make them aware of the idea that at night kind of all bets are off. And we're going to talk about bruxism a little bit here today as well. So again, choosing the right occlusal appliance for your patient, that is our topic. First, I want to give you a little bit of a clinical pearl though. How many of you ask your patients, do you clench or grind your teeth? We've got, let's see, 570 some people on here. I'll bet a ton of you ask your patients, do you clench or grind your teeth? And then what do they say? They say, me, of course not. And you say, yes, you do, I can tell. And then as you can see on the expression on her face there, you have a little bit of a fight because the patient is thinking to themselves, well, I'm with myself all the time. I'm telling you, I don't clench or grind my teeth, so I don't believe you. So here's the clinical pearl. I'd like you to never ask another patient for the rest of your career, do you clench or grind your teeth? I'd like you instead to ask, are you aware of clenching or grinding your teeth? Now that seems like a very subtle nuance, but it's not. If you say, do you, and they say no, you're done. The conversation's over. If you say, are you aware, and they say, I'm not aware, then you can say something like, I think you might, or you have in the past. Let me show you why I say that. Now, the you have in the past is something important too, because I think we would all agree that current wear on the teeth does not necessarily mean current activity, does it? If you see a patient on Monday and they have evidence of bruxism, if they have tooth wear, you don't know that the night before they were actively clenching or grinding their teeth. You just know that at some point historically they have. And this is where you have scanned the patient. I guess you could be using an intraoral camera. I would strongly encourage you to get a scanner if you don't have one already. But this is where you can show the patient on a huge screen, here's what I'm seeing in your mouth. And this may be a current behavior or it may be from the past. And then you can have a dialogue with the patient and they will understand where you're coming from and why you are encouraging them to protect the teeth that already are showing some indication of wear. Now, let's see if this will work here. So again, nearly 600 of you on here. Let's see if we can play with each other here a little bit. So if you wouldn't mind in the chat, if you have a question, you're going to use the Q&A thing, and we'll have a little bit of time at the end for that. But in the chat box right now, answer this question for me. How much time should we spend with our teeth in contact during a 24-hour period? How much time would you say we should spend with our teeth in contact? I'll pull up the chat here and see what some of your answers are. All right, we got someone who's heard me lecture before. We have 2 hours, 20 minutes, 5 minutes, 10 minutes, 30 minutes, 1 hour, 2 to 3 minutes, 0, less than 40 minutes, 20 minutes, 3 hours, 20%, 5 hours, 10 minutes. Okay, so we got a whole bunch of stuff here coming in, don't we? That's a wide, pretty much grouping of responses. Everywhere from 0, we should never have our teeth touch, and that's probably an outlier, to 3 hours a day that our teeth should touch. And on the person who said 0, our teeth should never touch, I know where you're coming from, but I think that teeth should touch. I don't know about you, but in dental school, they put me through kind of that process of waxing teeth in occlusion and making sure they hit just right. And then in pros, they seemed very, very concerned about how the teeth came together. And if they never touched, you would think, well, why would they have taught us all that stuff if they never touch? So I think they do touch. And like I said, I think there's someone who's heard me speak before because they use the term 1% of the time. And this is kind of my thing. I hope to be known one day as the 1% occlusion guy. So our teeth should touch about 1% of the time, which is roughly 15 minutes in a 24-hour period. This is where I get this from. Again, most dentists will say this almost intuitively, that it should be around 10 to 20 minutes a day. But Dental Clinics of North America, 1969, they did this study to see how much tooth contact time should there be in a 24-hour period. And here's what they found: 17 and a half minutes total for this group. With chewing, it was 9 minutes. So your teeth do come in contact with chewing. By the way, something that we should probably point out is our diet may have changed a little bit since 1969, okay? I would propose that we have a softer diet in the 2020s than we did in 1969, where they had a less processed diet. So keeping that into account, that maybe they had to chew more with vigor in 69 than we do in 2023, let's take this with a grain of salt, but that would make our teeth probably contact even less today than it did back then, as you can pretty much eat chicken McNuggets and pudding and stuff with very little tooth contact. But back then, 1969, 9 minutes during chewing, only half a minute during swallowing with meals. And then in between meals, during the daytime, we have tooth contact about 25 times per hour with swallowing just saliva. With sleep, only 10 times per hour because there's less saliva produced. So at night, in that 8-hour period we have marked here for sleep, 1.3 minutes of total tooth contact time. Now, that kind of begs the question for me, well, what's a night guard doing then the other 7 hours and 58 minutes? If our teeth are only in contact 1.3 minutes during 8 hours. Well, I would say jokingly that the night guard is then doing an impression of a retainer, if you get my point. The night guard's only working when the person is biting against it. Would you agree? Otherwise, it is a retainer. It's just sitting on the arch. You could have an upper arch. You could have it on the lower arch. I don't care. But you have this piece of plastic in there, and it's designed purpose is to protect the teeth. If the person was a 1% occluder, as I like to say, would they really need a night guard? Well, maybe not, because their tooth contact is so short. This is 1.3 minutes over 8 hours. So here's the deal. These aren't the people that we are giving night guards to. Now, as I mentioned at the beginning, I don't think that there's a contraindication to having a night guard, because I believe we all will clench and grind our teeth from time to time. Maybe when they did this study, maybe these people just didn't do it then. Maybe the mechanism that they were using to determine tooth contact was foreign to them and weird, so they didn't clench or grind that night, and maybe they would normally. My point is, though, that we're using typically a night guard to protect the teeth from this bruxism behavior. That is what we're doing. The night guard, if they aren't clenching or grinding, is really just a retainer. So here's some other reasons not to use a night guard. To relax the muscles. Putting a piece of plastic on the teeth does not relax muscles. To stop people from clenching or grinding their teeth, putting a piece of plastic on the teeth does not stop people from engaging in the behavior. Or to treat bruxism. We're not really treating bruxism, are we? It's more that we are using these pieces of plastic to protect the teeth. And we know that as dentists. I would propose to you that our patients do not understand that, because I all the time have patients say, oh yeah, my dentist gave me a night guard and it didn't work. And I'll say, well, what do you mean it didn't work? Well, I still grind and clench my teeth. I'll say, well, yeah, of course you do it. The dentist's thought process was, it's kind of like you're banging your head against the wall and your dentist gave you a helmet. A night guard is really a tooth helmet. It's there to protect the patient's teeth from their behavior. So go to, are you aware of clenching or grinding your teeth? Are they aware of it? If they are aware of it, then you can have that discussion and come up with a treatment plan that makes sense based on their awareness of their own problem. If they're not aware of it, then we need to make them aware of it. And one of my favorite principles is throw the patient under the bus. Help them to understand this is their problem. I've had people come in and we'll use a night guard from time to time that has a little positioning ramp on it to kind of bring the jaw into a specific position when they close on it, or if they are grinding on it. And sometimes, and this appliance fits on the upper teeth, and they'll say, this wearing this hurts my lower teeth. And there's nothing on the lower teeth. The only time that the lower teeth could be hurt is if they are clenching against the upper appliance. And I'll ask the patient, well, how do you think that's happening, that your lower teeth are hurting with this upper appliance that you have in? Do you think that maybe in the middle of the night, the upper appliance is jumping off of your upper teeth and smashing into your lower teeth? And eventually they'll think, well, no, it's probably because I'm biting against the appliance and maybe I'm putting excessive forces there and that's hurting my teeth. I'll say, that's right. So it's the patient's behavior that is causing the problem, not the guard. So this is where I help them to understand what might be going on. And I don't know for sure. I don't know if that behavior is currently occurring or if it was only in the past, but we're going to learn from what we see and make a treatment plan based on this evidence that we have, and we're going to treat them empirically based on the evidence that we have. And with a night guard, we know that if they really aren't spending much time with their teeth together, it's not going to do that much. But for somebody who is spending a lot of time with their teeth together, this is where the night guard is going to be effective. Now, we all know that patients with temporomandibular disorders tend to spend a lot more time with their teeth together. This study, and this is one of many, many, many studies that teach such things, said that they spent 3 to 6 times more tooth contact period than people without temporomandibular disorders. And this can be during the day as well as at night. But we know, again, and you know this from your clinical experience, that oftentimes people with TMJ problems do, even sometimes they're aware of this clenching, grinding behavior, or their symptomatology will tell you that there's something maybe going on at night. They may wake up with jaw pain. They may wake up with pain in their teeth, with tension in their muscles. Now, is there a relationship between bruxism and sleep apnea? Well, I believe that there is, and we've done other webinars on this, and as Dr. Park mentioned, there's a bunch of different educational things that I've done that are at glidewelldental.com that you can learn more about this relationship. But just a couple quick slides on this. This is a study back from 2004 that had a lot of impact on our field. It's done by a friend of mine named Dr. Gilles Levine and his group. And in this study, they looked at people with known sleep apnea, gave them a flat plane night guard, and looked to see if this made their sleep apnea better or worse. What they found was that use of this flat plane upper night guard was associated with a risk of aggravation of respiratory disturbances. Half of the people, the sleep apnea got worse. That's a little scary. Now, I would propose to you that you have done this in your career. You've given people a night guard and it's actually made their airway, their sleep apnea, worse. Now, they probably didn't come in and tell you, hey, that night guard you gave me made my sleep apnea worse. That's probably not what they said. What happened is when they came back for follow-up, you said, how's it going with the night guard? And they said, oh, you know what, doc, weird thing. I find I can't wear that night guard. Really, why not? Well, I don't know, but I'm just taking it out in the middle of the night. I find I'm waking up with it and it's in my hand. I've thrown it across the room. I find it in my sheets. I just can't wear it. You've probably had a few people over the years who have said, yeah, I'm sorry, I can't wear that night guard we made because it seems to make me choke. It seems to make me gag. It seems to make me snore. And I'm sure that many of you have heard your patients say that before. Right after that study, if you see down here, 2005, the American College of Prosthodontists even went so far as to say practitioners should screen patients for obstructive sleep apnea prior to fabricating a maxillary night guard. So this is not something new. I mean, we're going on almost 20 years since this position statement was made that dentists should be looking at this correlation between sleep, airway, and bruxism. Now, this is the Snore Plus screening that is also available at Glidewell in more detail, but I would just encourage you to be screening your patients prior to fitting a night guard and make sure you don't miss these folks that there may be an underlying sleep-related breathing disorder. The Snore Plus is basically your first question is, do you snore? And if they say yes, then you can ask other questions about if they've already been diagnosed with sleep apnea, if they have any comorbidities of sleep apnea. Again, there's more detail of this on other webinars. We won't belabor the point now, but please just have something simple for your screening with this. We just heard a minute ago, Roger Levin was talking about increasing production in your perio department and in your hygiene department. Well, are you aware that there's a correlation between periodontal disease and sleep apnea? People with periodontal disease seem to have a higher prevalence of sleep apnea than those without periodontal disease. Treating their sleep apnea, if they have underlying sleep apnea, can also help their periodontal disease. So these are not completely different things that we're dealing with as dentists. There are things that you can use in your practice to help the patient recognize if they are snoring. So for example, if you use that Snore Plus method, you're going to ask, do you snore? And the patient may say, well, I don't know if I snore. I don't have a bed partner. The dog or the cat don't tell me if I snore. So this is a great app that you can use. It's free, or there's a kind of professional version that's $1 or $2 that will give baseline data and also comparative data over time. Can be very, very helpful. Now, let's talk about using a so-called sleep appliance as a provisional, basically using it to protect the teeth but also seeing if it helps a patient with their snoring. So let's say the patient does say, yeah, I snore. Well, could you use something like the Silent Night or the EMA to treat their bruxism, but also to determine if a mandibular advancement device helps with their snoring? I believe you can. And this is, as my slide shows here, the crossroads of diagnosis and treatment. We are treating empirically. We think the person may have an issue, so we're going to treat them. But the main reason you're treating them is for their bruxism. You're treating them for a dental issue. I mentioned Gilles Levine a second ago, and he was on a webinar for a group that I'm part of the other day. And I asked him point blank, Dr. Levine, and he's considered the world's expert in bruxism. I said, is a mandibular advancement device like the ones on your screen right now, would you consider that state of the art for the treatment of bruxism? And he said, absolutely. So don't get too worked up about, well, gee, if I'm using that, you know, an upper and a lower night guard that are attached in some way, whoa, now I'm into the world of sleep apnea and I need medical doctors involved in sleep studies and insurance, and oh my gosh, I just can't go there. Would using an appliance like the ones on your screen right now protect the teeth? Well, of course they would. And it might also protect the airway, which might be related to their bruxism in the first place. There are some people who are clenching and grinding their teeth or just posturing their jaw to try to protect their airway. Again, there's more information in GlideWell on that. There is, Dr. Park mentioned this already, but there's a whole series on getting started in treating sleep-related breathing disorders, and I would have you check those out. You can go to glidewelldental.com and check all of that out, all that free content. All right, so now let's get into the meat of our choosing the right occlusal appliance. So now, as you notice, I've got a few night guards there, and I do have a sleep appliance, the Silent Night. Now, you might want to take a picture of this so you don't have to go back and look at this online. And this could be something you could even print out, and a little decision-making guide here for what appliance would you use. And then we're going to go through each of these in the remaining minutes that we have here and help you decide, well, why would I use one of these over another one? But this is kind of a nice overview that you could just have there at your desk when you are deciding, hey, I think this person needs an occlusal appliance. Which one should I maybe use? All right, now let's kind of go through them individually. The clear splint is an excellent material. It is homogeneous. It is flexible. So it's really nice because you can kind of, the patient can heat it under some water and stick it in, and it has a real nice feel to that. Because it is a homogeneous material, it is less prone to staining or anything like that. It's an acrylic, so you can have this add with ramps or guide planes or anything that you want. You can work with the technicians at GlideWell, and they can do basically anything that you can think of with this material. Very precise fit, very comfortable, has a harder feel overall than some of the other appliances that I will discuss. You can bond with this with acrylic if you need to change vertical. This is a really, really nice material that's been used for years and years and years now with great success. Highly polished, very, very smooth, excellent choice in a homogeneous material. This would be my go-to in someone that's a more severe bruxer. We've kind of ruled out sleep apnea, let's say, and there's something going on that we haven't quite put our finger on yet, and they are really going to town. This would be a very robust appliance that can protect their teeth and not wear down really quickly. This is kind of showing, I think I've got, actually that's not a video, maybe it is video. Oh, it is video. This is kind of showing how this works. You put that in some hot water and show you how flexible it becomes, which is very, very nice for the fitting of this, making it easy for your dental assistants to fit as well as for the patient at home. They can warm this under some hot tap water, put it in, very, very, very comfortable. And it has this unique ability to go back to where it was made. So it's flexible, but it doesn't warp, which is really, really awesome. So that, again, be my go-to in someone that's a little bit more severe case, or you just want that flexibility. That's the clear splint. Okay, next would be our Comfort Hard Soft. Now, I've done a ton of the Comfort Hard Soft materials over the years. One of the really cool things I love about Glidewell is not only will they make all these things for you, but they also sell you the stuff to make them in your office if you want. So the Comfort Hard Soft is a thermoformed material, and you can buy a Ergoform machine from Glidewell and buy the discs and all this stuff. And so we make these appliances in-house and have for basically my entire career. So we have a lot of experience with this material. This is the most widely prescribed bite splint. We have the hard outer layer and the soft layer against the teeth. It is super comfortable, super comfortable. That hard outer layer, you can also bond acrylic to it. So anything that you might need to modify is great. And one thing that is not known widely about this is that soft layer, you can actually take it out if you want. How you do that is you take like a Bard Parker, and you even a Dental Explorer will work, but you work in between the soft and the hard layer and get a little bit of separation there. And then you can drip some acrylic monomer in there, and you'll be able to pull out the soft liner. It's like you got a bleaching tray left over. Now, why would you do that? Well, the only reason really to do that would be if you know that the person has some pending dental work and you want to give them something immediately, but then you want to modify this night guard throughout this restorative treatment plan. Being able to rip out the liner and flow in some acrylic could be beneficial. Now, frankly, these things are so inexpensive that you would probably just make them a new appliance, but just keep that in mind. There could be an indication that you would have in your practice, like, oh, actually, that would be helpful because we could start off with Comfort Hard Soft, then we could remove the soft liner and flow in acrylic if we need to in some certain circumstance, and then maybe get them back to the Comfort Hard Soft. Again, super easy to fit. Flexible around the teeth, easy for dental assistants to fit if that's allowed in your state, and patients find this super duper duper comfortable. Now we have kind of a newer one, and this is a 3D printed appliance. So what would be the advantage of this is that it is thin. The thermoform appliances, we have a specific thickness. The full acrylic appliances will tend to be a little thicker. With your 3D printed materials, you can go very thin and still have it be effective. So this would be kind of my go-to on a patient that, maybe a smaller mouth or kind of bigger tongue, which sometimes because they have a smaller mouth, but they're just real particular about anything in their mouth. This is also a very comfortable material. As it says on here, it's stain resistant, all this kind of stuff. It's going to be very effective, but this is going to the main advantage of the 3D printed is the precision of the fit and how small it is. Okay, so that is going to be unique to this. Also a homogeneous material, also with the 3D material that they with the acrylic that they are using to print this. I could be wrong on this. I don't think I am, but you can also bond acrylic to this if you need to. And then we have our Silent Night, which I'm using as just a example of sleep appliances in general. So not necessarily the Silent Night specifically, although it is a great option for this, but you could extrapolate this to other mandibular advancement devices. Now, again, you may be on and surprised that I am talking about a sleep appliance for what we're really discussing here of a Brux guard. But again, as you look at this appliance on your screen, would this do a pretty good job at protecting the teeth? Well, clearly it would. As a matter of fact, some of you may have even done dual arch appliances before for Bruxes and patients, giving them an upper and a lower. So the silent night is unique in that it keeps the lower jaw from falling backwards. We could use this in a patient who has evidence of bruxism. We're treating their bruxism. As far as your chart notes are concerned, you're treating their bruxism. You just happen to be doing it with the silent night. And if that patient comes back and says, oh my gosh, this thing you gave me to protect my teeth from my bruxism activity, I'm not snoring anymore. And I swear I'm not as sleepy anymore. Well, that may inspire you to talk to that patient's primary care doctor to say, hey, I'm treating this patient's bruxism, but I'm using a device that's state of the art for the treatment of bruxism. It keeps the jaw from falling backwards. And there is evidence that in some cases, an airway issue can be a reason that people are grinding and clenching their teeth. So that's why I'm using this, doc. But the patient's telling me they're snoring less now and they're feeling more rested. That makes me think they may have an underlying sleep disorder. What do you think? What do you think we should do, primary care doctor? And then let that primary care doctor drive the bus from there on. So that is a reason that you might consider that. You are treating someone for their bruxism, but you are also diagnosing, does this person have a possible underlying sleep disorder? Now, a couple other appliances that aren't on my graphic there, but that you can also get from Glidewell. You can get the NTI Plus, the NTI OmniSplint. There, I just mentioned a second ago, the dual arch appliances, the NTI OmniSplint is upper and lower with just contact in the point stop in the front. There isn't a mechanism there to keep the jaw from falling backwards, but again, would be sort of ultimate protection of the teeth with only anterior point contact. If you find that you believe is helpful for your patients, reducing the ability, again, it doesn't stop them from grinding, it doesn't relax their muscles. What it does is it makes it so that they can't contract as hard. As a matter of fact, let's go ahead and do this with me really quick. If you aren't familiar with these types of appliances, go ahead and palpate your anterior temporalis for me and bite down on your back teeth. Okay, bite down on your back teeth. You should feel your anterior temporalis contract tremendously. Now bite on your front teeth only. For most people, you'll feel a significant reduction in contraction when you bite on your front teeth versus your back teeth. That's the idea behind these anterior point stop deprogrammer style appliances, is to reduce the mechanical, through a mechanical mechanism, to reduce the ability for us to contract. What that has to do with, NTI stands for nociceptive trigeminal inhibition, which is a big way of saying that when you bite on your front teeth, your brain shuts down a lot of that muscle contraction because our front teeth aren't meant to have that much force. So these are excellent choices too, depending on what your goal is. All right, so I'll leave this slide up again for another second or two so you can take a picture of it. And my kind of matrix of why you might choose a clear splint versus a comfort hard soft versus a comfort 3D versus a silent night in treatment for bruxism. And again, you really can't go wrong. So there aren't really bad choices. If you said, Jamison, you can only use, one of these for the rest of your life for protecting people's teeth from bruxism, I don't know that I would feel terribly strongly on any one of these to be like, well, I must have that one then. I think there are good indications for each of these. And ultimately, it will be what you and your team members really like to work with, what works best in their hands with some training. But I hope that this little matrix here will give you some guidelines on what you might choose for different indications. Okay, and again, reasons to use a night guard. Night guards protect the teeth. They protect restorations. All of us will clench and grind our teeth from time to time. There are unpredictable forces that may be put on those teeth. A night guard is there to protect that. Also, it does act as a retainer on the arch it's worn, and using something like the silent night could be used as a diagnostic aid while also protecting the teeth. The very best oral appliance is the one the patient will wear. That's the art of this, is you determining what is that patient most likely to use. If you can figure that out, you'll be successful, because the appliance on the nightstand or in the retainer case in their bathroom bag is not effective at all, the one that they'll use every night, that's going to be the most effective. Okay, so that's it. Let's see, Dr. Park, if maybe we have a couple questions.
Oh, we certainly do have a couple questions. In fact, we have more than a couple. So we're gonna jump right into it. Dr. Spencer, sometimes patients will report that they clench and grind their teeth more when they wear this appliance. And that could have something to do with impinging on the freeway space, right? So what's the response? What's the action that needs to be taken?
Yeah, that's a great point. And I do think that that's the case, that we have this freeway space there. If we make the appliance too tall, then they may even rest on the appliance. If you think like a bite block you stick in their mouth, and they're kind of closing their mouth on it. So one of the nice things with actually all the appliances that we talked about today is they can be very, very thin. These are not bulky appliances. Even the Silent Night is very thin, 2 arches against itself. But if that is the case, that they think that they are grinding more, ironically, something that you could do in that case is add a little anterior bite stop, kind of like that NTI appliance. And as I mentioned, with all of the different night guards, you could bond with acrylic there, add a little point stop in the front, and their perception will be that that has reduced their clenching behavior. Now, again, they may still be resting on that front point stop, but they won't be able to engage the muscle activity as if they have posterior stop. But I would be aware of that. I think if that was your thought, Dr. Park, on the freeway space, I think you're right on. We don't want these appliances to be very thick.
No, actually, that was one of our colleagues from Montreal has been sharing some great thoughts. Obviously, is very well informed on this topic. Can you comment on making a night guard on the lower versus the upper arch?
You know, it's interesting. So we typically do the upper. However, that's because, again, that mandible is closing onto the upper. And sometimes we will use bite ramps or anterior guidance a little bit to guide the jaw. However, my friend, Dr. Levine, he likes, if he's going to use a single arch appliance, he will oftentimes use a lower arch appliance because he thinks, well, maybe that will position the jaw a little bit when they close. So I think it has to do more with what's their overbite, what's their overjet, and really also what will they wear. The advantage of a lower appliance would be, and we'll do this a lot, if we have a patient and maybe they can't afford an upper for night and a lower for the day. And this person says, you know what, I catch my teeth together all the time. I'm at work, on my computer, I'm driving in my car, my teeth are together. We'll give them an appliance to try to help them break that habit. A lower appliance is going to be a million times easier to wear to work than an upper appliance. An upper appliance is visible, makes them talk funny. So that may be another indication that you might.
You know, we had a question about daytime bruxism, and basically the same thing. I mean, daytime is obviously something that can be controlled behaviorally, but do you control it behaviorally by making them an appliance?
I often do, and I call daytime appliance. Now, sometimes we will use these to position the jaw specifically for joint issues. However, a big use of a daytime appliance is to get that person towards what I call 1% occlusion. If they are clenching and grinding during the day, they're typically not aware of it. They're aware of it, but they're not aware of how much. It's just a bad habit. If you put something between their teeth, their brain is like, whoa, what's this? Why am I biting on this weird thing? And it can make them aware of it. And in my experience, most people within a couple months, they will get in control of this. They can then go without it. And then maybe they need something at times of stress. A lot of people, like you're in California, Neil, a lot of people get on that 405, they're going to clench their teeth. just
Right. Now I have a lot of questions about people who experience a change in the way their teeth come together because of wearing either a double arch appliance or a single arch appliance. What is the reason for that, and what is the action that should be taken?
Yeah, great question. And this is why also I combine night guards, sleep appliances. These are all occlusal devices. And historically, we've thought of a deprogrammer which we would think of kind of an NTI. We would think of that. And that may allow the jaw to go into this deprogram spot, the program being the occlusion, the maximum intercuspation. I treat every piece of plastic we put between the teeth as a deprogrammer. And as such, I will, for our sleep apnea patients, we always do this, but for even your night guard patient, you might want to have a discussion with them. They're like, hey, when you wake up in the morning, your bite might feel weird. And I want you to tap your teeth together every night before you go to bed and make sure your bite feels normal. And if it doesn't, I need you to call me. And you've seen me talk about this, Neil, when we treat for sleep apnea, we actually make them something that helps return their bite to their habitual occlusion. For a typical night guard, that's not necessary. Usually the bite is off very subtly and their bite is back to normal within a few minutes. But if you had a patient that really was a struggle for them, there are things that you could make. Again, there's videos on glidewelldental.com of me talking about what I refer to as a morning reprogrammer.
Right. Or an AM aligner. It's also called. Yeah. So, Jamison, so with the AM aligner, that's based on the theory that this is due to some swelling within the joint, some fluid that's changing position. Are there some times when habitual use of an appliance will actually cause the teeth to move?
I don't think so. Well, I shouldn't say it that directly. So let's say you're using a silent night appliance. You've got basically two retainers. You got an upper retainer and a lower retainer attached with bars. If the retainers still fit, theoretically the teeth haven't moved. So your comment about fluid in the joints, that's really what's happening. The person can't get their bite back because their jaw's been held forward for 8 hours, 6, 7, 8 hours. Typically that jaw will go back. However, in my experience of people with a bite change, and it's always a posterior open bite, and they've been treated by someone else, they come to us, whatever, they're referred to us. We can take the models of their teeth and hand articulate them. So I've been doing this 25 years, I've not seen very many where it's actual tooth movement. It's usually mandibular position change.
Now, how about like NTI, where you're really just having contact? Well, that's the same thing. If you use the Omni Splint, then you've got retainers on both arches. Right. But if you just use the one that fits on just the anterior teeth, you could actually have some posterior tooth movement.
That's correct. And now the good news is I've seen people over the years too, and they had what was perceived to be super eruption of the posterior teeth. They're hitting on their second molars. We were concerned about that. We took impressions of their teeth and bang, hand articulated right where they used to be. So number one, make sure you have good records and you keep them forever. But my recommendation there too, if I am using an NTI style appliance, I like to use one that has full coverage just so we can get rid of that part of the equation. I don't have to worry about, did those second molars move?
Yeah, it's interesting here because I have a question about what type of night guard should I make for someone who also needs to wear removable ortho retainers. Well, almost any of them is also a retainer, right?
That's right.
Exactly.
Absolutely. And what I would do in that case, Neil, is they've got the scans from that final equation. They send that exact scan, not a new scan, that scan to Glidewell and have the appliance made on the exact scans. And then that they're made in the same position.
And then when they lose that retainer, have another one made on that original scanner. Exactly. Here's one I haven't seen before. I really love to get your take on this. I recently had a request from a physician to have an oral appliance made for a patient with tinnitus or tinnitus, pronounced both ways, which is ringing in the ears, which so many people my age are suffering from. What are you familiar with an oral appliance as treatment for tinnitus?
Yeah. So a lot of people with TMJ problems will have ear-related symptoms. This goes back, I think there actually might be a video with me on Glidewell on this topic. I'm almost positive there is. It goes back to embryology, actually. So our jaw joints, the lateral pterygoid, muscles mastication, and the ear ossicles are all related from that first branchial arch, if we go way back to embryology. So there are some people that they have ringing in the ears, ear congestion, other weird ear symptoms that are related to a TMJ problem. And we'll see those things resolve with oral appliance therapy. However, having said that, I always get nervous when an ENT refers such a patient to me and they have no TMJ problem at all, though. So their chief complaint is ringing in the ears. Their range of motion is normal. They have no popping or clicking. They can eat beef jerky 3 meals a day and it doesn't bother them. So this person has no indication of a jaw problem, but they have ringing. That person, we may treat them still, but I'll use something maybe like an Occlusal, a little temporary water-filled splint to see if it changes anything. One other quick pearl is, and everybody can try this at home, if you have ringing in your ears, you can get in a very quiet environment and then try clenching your teeth or thrusting your jaw or opening your mouth wide and see if it changes the ringing. Maybe it'll change the pitch, the tone, the loudness, the softness. It will change something. If it does, in my experience, that's a good indicator that there may be a connection with your jaw there. On the other hand, if you do all this stuff and the ringing is exactly the same, that's probably nerve damage.
Yeah. Okay. All right. Interesting question here. And it's not exactly on our topic, but what type of appliance would you make for a full denture patient, a edentulous patient that snores?
That's super tough. So number one is, what have we always told those people to do with their dentures? Take them out.
Take them out,
right?
Right.
So number one, and I know this seems heretical, but getting rid of all of their vertical when they sleep, for some people may be hurting their airway, not helping it. So where I usually start is, why don't you try wearing your dentures to sleep? And if they do that and their bed partner or the Snore Lab app says, problem solved, I would work with their doctor to do objectively follow up and see if that actually helped. If it does help, then in my practice, since I'm not a general dentist, I would work with their general dentist to say, hey, this person needs to have a break from their dentures during the day, but therapeutically they need to wear them at night. So that's one. Number two, if they have money, then you would try to get them into a implant retained denture, and then you're going to be able to treat it like teeth. So that would be ideal.
Yeah.
Number three, they don't have money and you have to work with the denture, and it's not simply just wear your denture at night. Now you need actually something to hold their jaw forward. Well, number one, good luck, because they need to have really good ridges. They have to have a great anterior upper ridge or there's nothing to hang on, and they have to have a great mandibular ridge or the mandible just falls out. So assuming they have great ridges, then you can fit a sleep appliance over the dentures, and I'll usually use something like a dorsal fin appliance, something interactive, or another one that would work really well is there's the Silent Night with the Glidewell hinge, which is a Herbst style appliance. The reason that would work is it's not retention based. You don't have to have great retention, and it will fit on the denture teeth pretty well. It's never going to be awesome though. So yeah. Heads up.
I mean, I would just think that the force you're using to try to move that lower jaw anteriorly is going to dislodge that anterior denture. I mean, that lower
really
denture.
hard.
I don't really know how you would prevent that. That's a tough one,
Yep.
Very tough one. Let me just see if we could finish with one. Maybe if you would just make a final comment about treating patients for bruxism and what kind of screening you have to do for sleep apnea, just to make sure you stay out of trouble.
Yeah, I think that Snore Plus thing is great. And I didn't put these in the slides, but just a really simple acronym for screening is SNORE. So S, do you snore? N, can you breathe through your nose? O, do you have obstructions? Does your bed partner ever notice you stop breathing when you sleep? R, do you have gastric reflux, heartburn? And then E is what I call everything else. Do you have any of the effects? But if I was treating someone, and we do this all the time, because again, my practice is TMD and sleep. So a ton of our TMD patients come in, they've been given night guards, things like that. Literally, Neil, before we will fit a night guard, I do what that Academy of the College of Prosthodontists has recommended, and we rule out sleep apnea. Now, ruling out sleep apnea can be as simple as, Neil, do you snore? You don't? Okay, you probably don't have sleep apnea. I know that seems super simple, but that could be it. On the other hand, Neil says, yes, I do snore. Well, has your wife ever mentioned that you stop breathing? You know what? She has. Okay, shoot. So I'm already with 2 questions thinking, crud, I think we may have an issue here. And then I think this is where this provisional mandibular advancement device treatment comes in. In that case, rather than a flat plane night guard, I would give the patient a silent night. It's going to protect their teeth. It's going to help to protect their airway by keeping their jaw from falling back. Patient comes back and says, you know what? The wife says I'm not snoring anymore. And I swear I'm more alert at work in the afternoons. Now I'm going to call that primary care physician and say, hey, here's my findings. Here's what I've done. What do you think, doc, should be the next steps? That's what I'd recommend.
Excellent. Excellent. And I know I said that was the last question, but I lied. So no, because I meant to ask you this one and this, and I've got maybe 3 or 4 questions. When I deliver that occlusal appliance, what occlusal scheme am I trying to get? Am I trying to get anterior contact, posterior contact, even contact? And how important is that?
That is such a great question. And here's my take on it. I learned this from Terry Tanaka, who many of you know. I consider him one of my mentors. He wanted his oral appliances to hit on both sides. That's it. And think about it this way, is that the level that you will go to in your dental chair is frankly irrelevant, because they ain't sleeping in your dental chair. They're going to go home and they're going to be laying on a big thick pillow, a thin pillow, laying on their back, on their left side or the right side, on their stomach with their head to the right, to the left. It's not going to be relevant. So I think what you want to do is help the patient to recognize that the goal is for them to not touch the dang appliance. Their goal is to have 1% occlusion. I think if you spend 45 minutes trying to adjust it perfectly, that's almost telling them, this is the goal. I want your teeth to touch it. No. I wanted to hit on both sides. This is a protector. This is a helmet for when you bang your head against the wall. Okay. So that's how I kind of teach that too, is hitting on both sides. The patient should feel it, but then you visually check. Yep, sure enough, hitting on both sides, we're good.
Dr. Jamison Spencer, always good, practical advice delivered in an interesting and entertaining way. What more can we ask for? Thank you so much for, again, delivering the webinar for us. And thanks to all of you for joining us today. Thanks to our brilliant panel. And join us next week when we'll have, as always, our business advisory panel. And Dr. Charles Schlesinger from Albuquerque, New Mexico will be our speaker. And we're going to move over to the world of digital dentistry. And he's going to talk about integrating digital dentistry into a very busy general practice. So let's meet back here next week, same time, and we'll see you then. Thanks, everybody.